Hello and welcome back to Crash Course. Today we're going to be looking at the cardiovascular revision again, but this is part 2. In the first video we looked at the basic principles of the cardiovascular system alongside anatomy and embryology. And in this video we're going to focus on the innervation of the heart and the blood pressure. And whilst we're looking at that, we're also going to have a look at blood and the circulatory system in general. So to start with, innervation of the heart. This is dominated by two types of cells. The first type is a nodal cell, and the second type is a cardiomyocyte. So nodal cells are responsible for initiating the wave of excitation which passes through the cells by gap junctions into the myocytes, which allows the contraction of the heart. And this is dominated by L-type calcium channels. On the other hand, you have cardiomyocytes, which are muscle cells or myocytes that make up the cardiac muscle itself, and this is dominated by sodium channels, so voltage-gated sodium channels. So let's have a look at each one in a little bit more detail. So first of all, nodal cells. So in nodal cells, the resting potential is less negative than most somatic cells. So you can see the resting potential here is around -60, -70. This depolarization is due to the opening, as we've already said, of L-type calcium channels, which leads to a rapid influx of calcium here in this stage 0. Once the membrane potential has become positive, the slow voltage-gated potassium channels then open, causing gradual repolarization of the nodal cell, and this repolarization is aided by the closure of these calcium channels. So it's almost like a multi-system function in order to allow repolarization, in the respect you've got calcium channels closing as well as potassium channels opening. You've also got a slight overshoot of potassium, so this leads to hyperpolarization. And the HCN channel is activated by the hyperpolarization. It exchanges sodium into the cell and a potassium efflux, but mainly sodium, leading to that gradual reaching the threshold. So this is stage 4, so it's a gradual increase of sodium going into the cell and potassium going out. So it's a restoration of the resting potential. On the other hand, you've got cardiac myocytes. So when the action potential arrives and the threshold potential is reached, then the voltage-gated sodium channels open, leading to a rapid influx and depolarization of the cardiac myocyte, which can be seen on stage 0 here. So what's really important about this is this one is sodium dominated, where the other one was calcium dominated. Membrane potential reaches +20, so notice the differences in the numbers. So this is starting at -90 and getting up to +20, whereas in the last one, if we take a look back, we can see it's starting at -70 to get to around +10. So, where were we? The membrane potential reaches this +20 in depolarization, and the fast-acting potassium then open, and the efflux of potassium leads to a reduction in the membrane potential. At the same time, like in the last system, the sodium channels are closing. Soon, the L-type calcium channels, so they appear in this one as well, they start to open, and a calcium influx occurs, which balances out the potassium efflux, which leads to this plateau stage here in stage 2. Finally, in stage 3, these calcium channels close and the slow-acting potassium channels open, which causes repolarization of the cell. The resting membrane potential is then restored by the sodium-potassium ATPase in preparation for the next action potential generation. So think about innervation of the heart in general. It's a group of structures that send impulses through the heart. The SA node, as we discussed earlier, is the pacemaker, and it generates the impulse and sets the speed, and it's located in the wall of the right atrium. Then you've got the AV node, and this delays the impulse slightly, so it sits between the two atria, just above the ventricles. Then you've got the bundle of His, which has two branches, and this sits between the ventricles, and it's distributed to the Purkinje fibers, which are the last part of innervation, which sit in the lateral walls of the ventricle and distribute the impulse from the bottom of the ventricles upwards. So remember these simple 4 steps: SA node, AV node, bundle of His, and Purkinje fibers. So this is it in a more diagrammatic view, so you can see that the SA node is sat here in the wall of the right atrium. The fibers pass down to the AV node here, which delays the impulse slightly, to allow complete emptying of the atria. Then it goes down for the AV bundle, through to the Purkinje fibers, which as you can see distribute from the bottom upwards to allow a complete forceful contraction up through into through the semilunar valves of the aorta or the pulmonary trunk. So the action potential in general is quite an important concept, and understanding the basic action potential allows you to understand cardiomyocytes and nodal cells as well. So in a basic action potential, we should know that this essentially has a resting potential, and this is where you have 3 sodiums being pumped out of the cell and 2 potassiums being pumped in, and these are against the concentration gradient. So to start with, you have more sodium outside the cell and more potassium in, and they're being pumped against the concentration gradient. So then you have depolarization. So this is where you have a sodium influx into the cell, you reach your action potential, and then you need repolarization. So this is when you have a potassium efflux out of the cell. And then you have a refractory period or hyperpolarization, where your potassium channels are closing, but they close so slowly they cause a dip in the membrane potential. Another thing to point out are failed initiations. So if threshold is not reached, an initiation of an action potential will not occur. And then you return to stage 1, for resting state again, for that resting membrane potential. So we also have to think about the innervation of the heart from an autonomic nervous system point of view. So our autonomic nervous system is the parasympathetic and the sympathetic. And the way we think about these is parasympathetic is rest and digest, and sympathetic is fight and flight. So what that means is that parasympathetic is all about relaxing. It allows us to decrease the heart rate, allows us to decrease the force of cardiac contractions, and dilate the coronary resistance vessels. On the other hand, your sympathetic nervous system is all excitatory. It increases the heart rate, increases the force of those contractions, and constricts the coronary resistance vessels. So this is it from a more diagrammatic point of view, if you would like to appreciate diagrams. So coming from the medulla here, you can see the parasympathetic goes via the vagal route, and this allows us to relax, to decrease the heart rate. And alternatively, the sympathetic comes from down here, and this allows us to act on both blood vessels and the heart to increase the heart rate, but also increase the resistance in the blood vessels. So this brings us on to blood pressure. So this is happening in the blood vessels. What's your normal blood pressure? Well, it's 120/80, and we describe this as systolic over diastolic. So this is a normal artery, for example. However, the arteries can become vasoconstricted, which means they tighten. And the reason this happens is because of an increase in the sympathetic nervous system, where vasopressin and angiotensin II are released, causing this vasoconstriction. It increases the contraction around the artery, and it increases the resistance as well, which means pressure is increased, and therefore blood pressure goes up, because you have a decreased blood flow. Now let's think about the alternative thing that could happen, so vasodilation. And this happens due to a decrease in the sympathetic nervous system. And this happens when you have a release of histamine, and histamine causes nitric oxide to be released, which is a potent vasodilator. So, when you have vasodilation, it decreases the circular smooth muscle contraction around the artery. It decreases resistance, and you have increased blood flow, which causes a decreased blood pressure. Next concept to get your head around are bioreceptors. So bioreceptors are sensors located in the blood vessels, and they sense blood pressure and relay the information to the brain and tell the heart to change that blood pressure. So if you have a low blood pressure, you need to increase your cardiac output, and if you have a high blood pressure, you need to decrease your cardiac output. So think pressure when we think bioreceptors. And examples of bioreceptors are in the internal carotid artery and also in the aortic arch. On the other hand, you have chemoreceptors, 2 very similar concepts, don't get them mixed up. So chemoreceptors, on the other hand, are special sensors that detect changes in chemicals present. So it's not as much to do with blood pressure, it's about chemicals, and causes the body to react there. So peripherally, it can respond to changes in O2, CO2, and pH, and centrally, or in the medulla, it can respond to changes in CO2 in the CSF. So think chemical substances when we think of chemoreceptors, and think peripherally about those carotid bodies and aortic bodies. So again, in the diagrammatic view, you can see the location of the chemoreceptors and bioreceptors on this diagram, and what's really important is that you don't get them mixed up. Next, we have the RAS system. So this is something that is linked to blood pressure, so the renin-angiotensin-aldosterone system, and it's something that was probably covered in the endocrine block. So what happens here is that the liver releases angiotensinogen. It combines with renin, which is released from the juxtaglomerular cells of the kidney, and this forms angiotensin 1. This combines with ACE, which is released from the surface of the lungs, to form angiotensin 2. When angiotensin 2 causes all these actions, and the ones that we're bothered about for the cardiovascular system are arteriolar vasoconstrictions, causing an increase in blood pressure, and also an increase in sympathetic activity, because that also leads to vasoconstriction. So blood in general now. So blood, key terms to know: hypertension is blood pressure too high, and hypotension is blood pressure too low. So anything with hyper, it means too high, and hypo means too low. Be aware that blood is made up of plasma in 55%, red blood cells in 45%, and the remaining 1% are white blood cells and platelets. So red blood cells in particular are what we're bothered about here, and they have a large surface area with no nucleus, which means they've got more space to carry that oxygen around the body. They also contain hemoglobin, which binds to and carries the oxygen, and it also gives red blood cells its red colour. And red blood cells also have a biconcave disc shape. So the circulatory system, master this is something I never got in first year, but actually it's really simple, and this is just a nice simple diagrammatic view to allow you to think about the blood vessels coming out of the heart. So as you know, when you come out of the heart, when you come out of that left ventricle, you have your aortic arch, and there are 3 branches to the aortic arch before it goes down into the abdominal aorta. So you have your brachiocephalic trunk, you have your left common carotid, and you have your left subclavian. And your brachiocephalic trunk branches in to these two, so the right common carotid and the right subclavian. So essentially the 4 main branches are the subclavians and the common carotids coming off, but on the right hand side it goes to a brachiocephalic trunk before it branches into those. So then thinking about further branching, the common carotid goes up and it branches into an internal and an external carotid on both sides. Now if you think about the subclavian, this is the one that's going towards your shoulder and your arm. So as it goes towards your shoulder, under the armpit, it's your axillary artery. Going down the arm, it branches into your brachial, and then into your ulnar and radial. And then it goes into the palmar arches of the hand. But what's really important is this is a simple diagram that's showing that the subclavian is all about going to the arm, and that the common carotid is all about going up towards your neck. Now, of course, these aren't the only branches. Off of the subclavian, you also get your vertebral artery, and you'll learn about this in the neuroblock, but this goes up as well towards the head and neck. So, on the right hand side, this is just repeated. You also have your vertebral artery, and all down that right hand side, it mirrors the left hand side. You have that same blood supply. Now, don't be fooled into thinking these are the only branches. They're not. This is a simplified diagram to allow you a basic understanding of where the blood goes when it comes out of the heart. So it's either going to go up these 3 branches here, or it's going to continue down through the abdominal aorta to supply the rest of the abdomen. Another part of the circulatory system which is really important are the coronary arteries and coronary veins. Now the coronary arteries supply the myocardium of the heart, and just like any other organ or tissue in the body, the heart needs that oxygen-rich blood to survive. So the aorta branches off into 2 main coronary blood vessels, the right coronary artery and the left coronary artery. The right coronary artery supplies the right hand side of the heart, which isn't as big as the left because the blood's only going to the lungs, remember, so it's not got as much muscle. But the right coronary artery supplies the right hand side with these branches here, with the marginal artery and the posterior interventricular artery. The left coronary artery is bigger, and it branches into the circumflex artery and the LAD, or the anterior interventricular artery. And like any system where you have arteries, you need veins. So the coronary veins are really important in draining that deoxygenated blood back from the heart. So the coronary sinus is probably the most important structure of note, and that is a collection of veins joined together to form a large vessel, and it returns that less oxygenated blood back to the right atrium, alongside the superior and inferior vena cava. Be aware that you've got a great cardiac vein which travels down here, the middle cardiac vein travelling down here, and then the small cardiac vein which travel down this right hand side, down this right ventricle. Be aware of where these veins pass, be aware of where the arteries pass, and what part of the heart they drain, because that can also come up in your exam. That's everything for this video. Join us next time where we will be looking at the histology of the heart as well as the cardiac cycle and a basic ECG interpretation. Thank you very much. I hope you found it useful as always.